Yeah, so I'm Marc Chamberlain. I'm a trained neuro-oncologist, and I work at Lantern, and we have a spin-off company called Starlight, of which I am the Chief Medical Officer. One of the things that's probably most unique about Starlight is the fact that it's a company based strictly on treating brain cancer. And there really isn't another pharmaceutical company that has such an approach. And Starlight's approach is to really tackle the three major problems that we see with brain cancer. One in adults, which is predominantly gliomas, and glioblastoma being the largest entity that we treat. The second being brain metastases, which are the most common brain cancer that we see in adults. And then thirdly, pediatric brain cancers, which, albeit relatively small by comparison to brain metastases in adults or glioblastomas in adults, still comprise the second most common cancer in children, and clearly the most common solid cancer in children, of which there's a tremendous unmet medical need. My background as a neuro-oncology has been in a variety of NCI-designated cancer centers, most recently Fred Hutch in Seattle, Washington. Most adult brain cancers are gliomas, and most of those are glioblastoma. So an initial focus for Starlight will be in treating adult glioblastoma. We're completing a phase 1A trial now in adult solid cancers as well as glioblastoma. Our phase 1B study will have a number of components, but one arm will be exclusively dedicated to recurrent glioblastoma. And the challenge with glioblastoma in adults is that we have very few treatments. Our treatments generally are maximal safe surgical resection at initial diagnosis, followed by concurrent Temodar and radiation therapy, and then adjuvant Temodar after the completion of radiation therapy. Thereafter, when patients recur, they have very few options. These options include the possibility of a re-resection, of re-radiation, or the use of systemic agents such as bevacizumab or CCNU, an oral nitrosourea. However, the problem with recurrent glioblastoma is that survival is quite short, on average approximately 9 months. And current therapies have not changed that. And so there is an enormous unmet need for further therapies, in which we hope Starlight, in its first asset, STAR-001, will play a pivotal role as a novel alkylator. The second aspect of Starlight's focus is on brain metastases, primarily in adults. These are the most common brain cancer, anywhere from 100 to 150,000 new cases per year, compared to pediatric brain cancers, of which there are approximately 4,000 per year, or adult glioblastoma, of which there are approximately 13,000 per year. Brain metastases in adults generally have three fundamental treatments. Radiation therapy, which is the primary treatment, is done for essentially all patients. In those patients that have oncogenic-driven cancers, for which we have small molecular inhibitors such as tyrosine kinase inhibitors, many patients can be treated with relatively small and asymptomatic lesions with these drugs. Or in the case of melanoma, where we have checkpoint inhibitors, these can be active as well in brain metastases from such patients. However, all patients ultimately will require radiation therapy, typically given as either whole brain or, more commonly today, as stereotactic radiotherapy. There are patients who will benefit from a surgical resection, typically patients with large symptomatic tumors in relatively non-eloquent brain, as well as patients with single metastasis, in which case that would be followed by radiotherapy. The third focus of Starlight is in pediatric brain cancers, of which there are several, the most common being hemispheric gliomas, which are G34 altered, which is in the histone 3 family. And similarly, the diffuse midline gliomas, including diffuse intrinsic pontine gliomas, which are K27 altered, again, a histone 3 family of alteration, of epigenetic alterations. In addition to the hemispheric gliomas and diffuse midline gliomas, there's a third cancer predominantly found in very young children, infants in particular, called ATRT. And this will also be a focus of treatment in pediatric brain cancers. LP-184, or STAR-001, those are synonyms, is an alkylating intravenous chemotherapy agent that is derived from mushrooms. So it's a mycotoxin, but it's a fully synthesized drug. And it's undergone fairly extensive clinical testing in a variety of cell lines, as well as cell-derived xenografts and patient-derived xenografts, as well as orthotopic models. And it was in these studies that we discovered that there was a unique sensitivity of this drug to a variety of particular cancers, glioblastoma being one of those. So a unique feature of STAR-001 is the fact that it's a prodrug. In order to be converted into its bioactive form, it moves intracellularly, and an enzyme that's part of the pathway of prostaglandin catabolism, prostaglandin reductase 1, converts it to its active intermediate that then alkylates DNA. And this feature is unique for a reason as it relates to central nervous system in Starlight, in the fact that normal brain has relatively low levels of prostaglandin 1, whereas brain tumors, and glioblastoma in particular, has much higher levels, and the differential is about 1.3-fold higher in tumors than normal brain. And this would suggest some selectivity for targeting tumors versus normal tissue. And one of the unique features of STAR-001 is the fact that it is brain permeable, and that's extremely important in treating central nervous system cancers. About 98% of current drugs that are commercially available to treat cancer do not penetrate the central nervous system, and as a consequence, in order to treat central nervous system disease, you need a drug that engages the target by entering the central nervous system. In addition, there are other unique features of this alkylator, one of which is that it alkylates at the N3 position of adenosine. And that is unique amongst alkylators, and we think creates a special vulnerability to cancers that otherwise typically see alkylator-based therapy that functions at other sites of alkylation. We know from preclinical studies that this alkylator, LP-184 or STAR-001, is sensitive in nanomolar concentrations relative to other alkylators, which typically are in micromolar concentrations in terms of their IC50. In addition, and what's unique about this drug is its mechanism of repair is through nucleoside excision repair. Most other drugs, such as temozolomide, are repaired through MGMT, another DNA repair pathway, or alternatively through homologous recombinant repair. And so unique to this agent is the fact that any DNA deficiencies, repair deficiencies, are uniquely sensitive to this agent. Taking advantage of that and leveraging work from our radar component of Lantern has allowed us to understand spironolactone and how it might allow us to further enhance the activity of LP-184, in particular through synthetic lethality. And spironolactone acts at targeting a unique enzyme in the nucleotide excision repair pathway, ERCC3, by ubiquitinating it and then degrading it through proteasome degradation, allows for increased sensitivity as seen in preclinical models. So our plan is to use this in combination with LP-184 to enhance activity as we've seen in preclinical models, and hopefully that will be realized as well in humans. So currently Lantern is running a phase 1A trial, and the phase 1A trials are dose escalation. The phase 1A trial is a trial designed to assess safety, tolerability, and to find a dose for expansion as well as for the phase 2 study ultimately planned. It currently includes patients with adult, recurrent, or refractory solid cancers, including recurrent glioblastoma. The inclusion criteria, like many phase 1A trials, are relatively open, i.e. patients need to be greater than 18 years of age, have an expected survival greater than 3 months, have been treated with standard of care, and don't have further therapies that are offered to them at this time. As well, patients can have any number of prior therapies before entering the phase 1A trial. Our plan is to have somewhere between 30 and 50 patients through this trial, and this will then be able to allow us to launch into a phase 1B, which is the expansion phase of the trial. The expansion phase of the trial will have 2 general arms. One arm will be confined to recurrent glioblastoma at first recurrence, having failed standard of care, surgery, Temodar radiation therapy, and will enter as a single-arm trial comparing both monotherapy as well as combination therapy with spironolactone. The role for spironolactone has been defined preclinically as being an agent that increases the activity, the efficacy of STAR-001, or LP-184 as it's also called, by way of inhibiting its resistance mechanism, which is repair by nucleotide excision repair. In particular, spironolactone targets ERCC3 with ubiquitination and ultimately degradation through the proteasome process. So this leads to synthetic lethality, and we hope, at least based on preclinical models, that this will prove to be the combination that we move forward with in our phase 2 trial. But initially we'll do a phase 1A followed by a phase 1B trial in recurrent glioblastoma at first progression that's IDH wild type, comparing monotherapy to combination therapy. The phase 1B trial will initially comprise approximately 10 patients in each arm, monotherapy and combination therapy, with at least 5 patients in each arm undergoing a clinically indicated repeat surgery. This will allow us to do pharmacodynamic evaluation on resected tissue, having treated these patients the day before planned surgery. Each treatment is given intravenously on day 1 and day 8 of a 28-day cycle. Spironolactone will be given as an oral drug, administered approximately 30 minutes before the LP-184 infusion, as a dose of approximately 200 milligrams. Starlight will run 2 contemporary phase 2 studies. Both will be randomized. In the first randomized trial, we'll assess glioblastoma at first recurrence and compare this in a small randomized study against the current standard of care, lomustine or CCNU, and oral nitrosourea. So that will be a study that will comprise probably somewhere between 70 and 100 patients. The second randomized phase 2 trial that will be run by Starlight will be in promoter unmethylated MGMT glioblastoma, newly diagnosed. So these patients will undergo maximal safe surgical resection, following which they'll be randomized between 2 arms. One arm will be LP-184 in conjunction with radiation therapy, and then LP-184 given as adjuvant therapy. The other arm, the comparator arm, will be standard of care, which will be temozolomide plus radiation therapy followed by adjuvant temozolomide. Again, this trial will be comprised of about 100 patients.